Good evening, everyone. Welcome to another live session of Conceptual Surgery. Today, we are discussing the topic of pancreatic neuroendocrine tumors. In the last class, last month, we have discussed the neuroendocrine neoplasms of the GIT, and today we are discussing the leftover topic from the last lecture, which was neuroendocrine neoplasms of the pancreas. I am Dr. Adiba Nizam. I am working as a senior resident at present at Lady Harding Medical College. I have completed my MS in General MDMP from Maulana Azad Medical College. So this is, firstly, we are going to do a quick revision of what we discussed last time about the neuroendocrine system. So the neuroendocrine system in our body is consisting of neuroendocrine cells, which are ectodermally derived, and they are like neurons. They are activated by receiving an input from the neurotransmitters that are released by neurons. These cells then get activated, and in response to this neuronal input, they will release hormones, which will then be released into circulation and cause secondary effects on their target organs. So, in response to a neuronal signal, hormones are released by these cells, which are called neuroendocrine cells. So these cells are producing a multitude of amines, peptides, prostaglandins, catecholamines in response to this neuronal stimulus. These are synthesized with the help of homogranin A and stored in these cells in the form of vesicles. When the neuronal input comes in, these cells will release the chemicals stored in these vesicles into the bloodstream to cause downstream effects. So in this diagram, we see that nerves will act upon the neuroendocrine cells, which will in response release hormones, which will be released into the blood circulation, and then these hormones will produce their effects on the target. In our body, the neuroendocrine system is composed of two distinct forms. There is one is the solid neuroendocrine system, where we have the glands, which are well-formed glands in the form of the pituitary, the parathyroid, the medulla, adrenal medulla, and the paraganglia. Then we have a diffuse neuroendocrine cells, which are distributed throughout organs such as the GI tract, the respiratory tract, the pancreas, thyroid, thymus, and the urogenital tract. So last time when we discussed, we had left out the pancreatic neuroendocrine cells, and we had discussed the neuroendocrine tumors arising from the GIT, the stomach, the small bowel, the large bowel. So today we are going to be discussing the neuroendocrine tumors arising out of the pancreatic islet cells. So as we know, the pancreatic islet has multiple types of cells. The most numerous of these are the beta cells, which we see in this diagram, the beta cells which secrete insulin. In the islets of Langerhans, these are arranged centrally. And surrounding them, the pink cells that we see are the alpha cells which secrete glucagon. And dispersed in between, we have the delta cells which secrete somatostatin, the F cells secreting pancreatic polypeptide, the G cells secreting gastrin, and we see these blood vessels. The blood flow also in the islets of Langerhans is from center to out, center to the periphery. So first, the perfusion is to the beta cells, and then onto the alpha cells, and that is how the control of alpha cell secretion is through beta cells. Because the blood flow is first through beta cells, insulin will be released, which will be acting on your alpha cells, and thus regulating the release of glucagon. So when we have these cells, the tumors that arise from these cells are called islet cells. They used to be called islet cell tumors, and we have the name of the tumor, neuroendocrine tumor, based on the cell of origin and the product that it will be secreted. So we have insulinomas, glucaginomas, somatostatinoma, gastrinoma, VIPoma, depending on what the peptide is being secreted. So, brief introduction to pancreatic neuroendocrine tumors. These are rare tumors. They form only about 3% of the pancreatic cancers. As The older term used was an islet cell tumor, but the term that is now preferred by WHO for GI tract and pancreatic neuroendocrine tumors is a gastroenteropancreatic neuroendocrine tumors. Most commonly, when we talk about pancreatic neuroendocrine tumors, the most common variety is the non-functional. In the functional tumors, the most common type is the insulinoma. We'll be coming to this later also. And most of the cases will be in the age group of 40 to 70. These are mostly, they will be occurring in the sporadic form. In familial form, most common association is with MEN1 syndrome. And other associations can be with tuberous sclerosis, von Hippel-Lindau, and neurofibromatosis. Okay, so this slide is demonstrating the common types of the neuroendocrine tumors. As you can see, the most common is the non-functional one. In the functional tumors, the most common is the insulinoma. So all of these tumors are, irrespective of whether it's an insulinoma or a gluconoma, whatever the tumor is, these are staged in a similar fashion. And there are two types of staging. As we discussed for the GI neuroendocrine tumors also, the same staging applies. One is the AJCC 8th edition staging, and one is the WHO tumor grading that we will be following. So, as per the grading system for pancreatic NETs, we have three types of tumors, which is the low grade, the intermediate grade, and high grade. And how we divide these is on the basis of Ki-67 and the mitotic index. So, tumor has a mitotic index of less than 2 per high power field and a Ki-67 index also of less than 2%. We'll be discussing these in detail. What is a Ki-67 index? How is it calculated? How is the MID1 index performed? And this we have discussed in the class on GI neuroendocrine. So this is the well-differentiated low grade. Then we come on to the intermediate grade, which is when we have the mitotic index between 2 to 20 and the Ki-67 index also between 20%. These two, as you would note, are called neuroendocrine tumor or neoplasm. When we talk about the high grade one, it's called a neuroendocrine carcinoma, where either the mitotic count is more than 20 or the Ki-67 index is more than 20%. This is an important classification, and this classification remains same when we are talking about GI neuroendocrine tumors and pancreatic neuroendocrine. Now, moving further on, the AJCC also classifies these tumors based on the size and extent. So, a T1 tumor is less than 2 centimeters, a T2 one is greater than 2 centimeters, a T3 one is one which extends beyond the pancreas but does not involve the vessels, the celiac axis, or the superior central artery. And in the T4 tumor, it involves the celiac axis and the superior central artery, or it's an unresectable primary tumor. Lymph nodes involved, not involved, metastasis present, metastasis not present. So this is this would be the group stage on the basis of the T and M staging. Okay, moving on to the pathology. These are intraoperatively, when you encounter these tumors, these are well circumscribed nodular feeling tumors, and as is being seen in this particular diagram, that there is a pancreatic neuroendocrine tumor below the pancreatic duct, and this is the gross specimen. When we talk about the microscopic appearance, this we discussed last time also when we discussed GI tract neuroendocrine tumors, that these cells tend to form rosettes with a very high, very rich vascular supply. So rosettes are characteristic feature in neuroendocrine tumors.